As you can see here in this clinical picture of a Bowen disease, and with dermoscopy, glomerular vessels and scales. Glomerular vessels in center of dermal papilla. It is another example, and in this case was an early invasive squamous cell carcinoma, and in these cases, vessels, glomerular vessels may be larger, and they are hairpin or a little bit larger glomerular vessels in invasive squamous cell carcinoma. But these glomerular vessels may be seen also in ectasis dermatitis. But in this case, all the lesion had the same kind of vessels. It's all over the lesion, not just in clusters. The next type of vessels that we need to know, they are these vessels that we call polymorphous vessels. It means a mixture of linear irregular vessels, dotted vessels, and these kind of vessels are talking about melanoma again. And it is a thick melanoma with all these polymorphous and crazy vessels. We can see linear irregular, hairpin, glomerular, dotted, many kinds of vessels all together in a crazy distribution. It is melanoma. We have again another patient, red hair patient with a previous history of melanoma and multiple BCCs. Clinically, what do you think about this lesion? We should do dermoscopy, of course. And with dermoscopy, we have several clues for melanoma. We have dotted vessels, linear irregular, these white lines that we will see later, and this blue hue in the center, and also that vessels are predominantly in the center, and also some remnants of pigmentation around the lesion. You can see better these white lines, shiny lines. And now we are sure that this picture was taken with polarized light. And in fact, we know that vessels in melanoma are predominantly in the center, many times together with scar-like depigmentation or these shiny white structures, and many times associated with blue-white veil, as you can see here. And remember, when we see also remnants of pigmentation, we should think about melanoma. And also, if we are applying the two-step algorithm, we need to remember if we have a lesion with no specific criteria for melanocytic, but also no specific criteria for non-melanocytic, the lesion could be melanocytic and could be melanoma. Now we have another example of a lesion arising in the back of an albino patient. The patient had a congenital nevus, but it was changing in the last 2 years. Here you have the clinical picture and dermoscopy. And by dermoscopy, we can see also the lesion has no clear-cut criteria for melanocytic lesion, but we have many clues again. Remnants of pigmentation, these atypical vessels, and also these red, whitish areas, milky red areas. And here, linear, irregular, dotted vessels. Linear, irregular, and dotted vessels. Remember, again, when we have polymorphous vessels associated with also remnants of pigmentation and milky red areas, as you can see here, milky red areas, we need to think about melanoma. Milky red areas, remnants of pigmentation, polymorphous vessels are talking about melanoma. Now we have another flat lesion, completely different than the previous one, in the arm of a person with a personal history of melanoma. She was not aware of the lesion, and the lesion was discovered in a follow-up visit. And it is dermoscopy. What do you think about this lesion? How many of you think that this lesion is a melanoma? Yes, it is a melanoma. Again, we have dotted vessels, remnants of pigmentation, and these white lines. It is a melanoma. And these white lines, we call them chrysalids. These shiny white streaks are just seen when we are using polarized light. and cross-polarization dermoscopy. And even when we are changing the position of the dermatoscope, these lines will change because it's an optic artifact of the reflection of the light in the collagen. These shiny streaks, chrysalids, are associated with melanoma in the context of a melanocytic lesion, but also may be seen in other tumors, as Dr. Malvey showed to you. And not only tumors, may be seen also in this lesion, also pink lesion, with this dermoscopy. Do you know what it is? Lichen planus, perfecto. Yes, these shiny white lines that we can see in lichen planus, associated with linear vessels and sometimes blue-gray dots. Another pink lesion. What do you think about this lesion? It is melanoma? BCC? BCC, yes. And dermoscopy, what do you think? Melanoma or BCC? Melanoma. We're more in favor of melanoma. And you are right, it is a melanoma, but what is this? It is a crust? Is it a crust, or what it is? In this case, we use confocal microscopy, and I know that Marco Ardigo will explain to you about this technique. And we focus in this area. And this area was just melanoma cells, a specific clone of melanoma cells in this area. We need to remember that these milky red areas are talking about melanoma. As we can see again in this lesion that Dr. Malvey showed to you, that it could be similar to a pyogenic granuloma. The dermoscopy is the same in pyogenic granuloma. Milky red areas, whitish structures that are crossing the lesion, and white collarette. But it was a very thick melanoma. And it is a true pyogenic granuloma. And it is a true pyogenic granuloma. But under dermoscopy, we cannot differentiate them. For this reason, we suggest always to perform histopathologic confirmation of these many, many times benign lesions, but few times, but very dangerous melanomas. Another type of vessels that we can see in melanoma are corkscrew vessels. These coiled vessels that are characteristic of very thick melanomas, and especially metastatic melanoma. It is a patient with a previous history of acral melanoma in a finger, that an eruption appeared in the arm. It appeared in few days, and it was diagnosed as herpes zoster. But when the patient arrived to our visit, we did dermoscopy. And do you think that it is a vesicle? Of course not. We can see corkscrew vessels, and they are all metastases. Even very small lesions, 2 millimeters, with corkscrew vessels, and even less than 1 millimeter, even with corkscrew vessels. It is a very important clue to identify very, very early skin metastases. The other type of vessels that all of you know perfectly well are arborizing vessels, and you know perfectly well that they are characteristic of BCCs. Always we have some exceptions, and some nodular melanomas may exhibit this kind of vessels, very rare, but these vessels are characteristic of BCCs. As you can see here, these very, very nice arborizing vessels, always completely in focus, because they are running in the surface of the tumor. Another example of these arborizing vessels that sometimes are stopped because the pressure when we are taking the pictures, and we call them truncated arborizing vessels, because we perform a little bit of pressure during the picture. And as the vessels are very superficial, we can produce this artifact, but they are arborizing vessels. Another example of these arborizing vessels in a BCC with a central ulceration, an additional clue in favor of a BCC. Sometimes in superficial BCCs, we can see some thin vessels a little bit arborizing, but not too much. Many times associated with many superficial ulcerations. And with these pink areas, this pattern is characteristic of superficial BCCs. Again, another superficial BCC, in this lesion we see again this very small arborizing or thin vessels, but also many ulceration, and also these structures that we can call them maple leaf-like areas, or as you like. La foglia, in Italian, I think so. Okay, another BCC with a truncated vessel because the pressure. Another type of vessels that we need to know are hairpin vessels. Hairpin vessels may be seen many times in keratinizing tumors. As you can see in this clinically non-pigmented lesion, that with dermoscopy we can see many hairpin vessels, sometimes surrounded by a whitish halo, and it is characteristic of a keratinizing tumor, and it is just a SEPK, irritated SEPK.